Metastatic lung tumors. Lung is frequently the site of metastatic neoplasm. The carcinomas and sarcomas arise anywhere, spread to the lung via blood, lymphatics, or direct invasion. Esophageal carcinomas and mediastinal lymphoma extend by direct invasion. Pulmonary metastases are common. They most frequently occur with the tumors that have rich vascular drainage. Examples include renal cancers, bone sarcomas, choriocarcinomas, melanomas, testicular teratomas, and thyroid carcinoma. Most pulmonary metastasis arises from the common tumors such as breast, colorectal, prostate, bronchial, head and neck, and cancers. The intravascular emboli occurs most commonly with hepatocellular carcinoma and adenocarcinoma of the breast and stomach. They may be associated with lymphangitis carcinomatosa, the lymphatic invasion. The pulmonary nodules are the most common manifestations of secondary neoplastic disease in the lung. They usually derive from the tumor emboli arising from the invasion of the tumor capillaries. Tumor emboli drain the systemic veins and the pulmonary arteries. They subsequently lodge into the pulmonary arteries or arterioles and extend into adjacent lung tissues. Pulmonary nodules are usually multiple, spherical, and variable in size. And tumor can be spread by direct spread of carcinoma, especially in the esophageal tumor. Pulmonary metastases are usually multiple. They vary in size from 3 mm to 15 cm or more. The nodules are of the same size and are believed to originate from the same time in the single shower of emboli. The numerous tiny nodules mimic the pattern of miliary tuberculosis. Nodules are found most commonly in the outer third of the lung, especially in the subpleural regions or zones. They can be spread by lymphatics, bronchial tree, or air elimination. A pneumothorax associated with pulmonary metastasis usually indicates an osteosarcoma at the primary site. Calcification is seen in the metastasis from osteogenic sarcoma. Hemorrhagic metastases with a halo of hazy opacities are most commonly seen in choriocarcinoma, but can also occur with the appearance of vascular tumors such as angiosarcoma or renal cell carcinoma. Metastasis from teratoma of the testis may show complete fibrosis or necrosis after chemotherapy. So, lung is the most common location of metastasis for primary tumors. With third of all the cancers, the patient will have pulmonary metastasis at some stage. Pulmonary metastasis most commonly occurs secondary to hematogenesis spread, and it is likely that undetected micrometastases are already present in many patients with detectable lung disease. The most common primary tumor metastasizing to lung are colorectal, breast, renal, and head and neck tumors. Rarer tumors where the lung is most likely to be location for metastatic disease are malignant melanoma, bone and soft tissue sarcoma, malignant germ cell tumor. Benign metastasizing glioma is a usual condition in which the metastatic pulmonary nodules appear in women with a history of uterine gliomyoma. The clinical course is usually indolent. In selected patients, the resection of the pulmonary metastasis may be indicated with the intention of prolonged survival. In patients with multiple pulmonary nodules in which the diagnosis is possibly the BATS, lung biopsy may be indicated as a result of the change in management as well as the multiple pulmonary metastasis. The differential diagnosis of multiple pulmonary nodules includes sarcoidosis, tuberculosis, rheumatoid arthritis, benign parenchymal lymph node granulomatosis, polyangiitis, formerly known as Wegener's granulomatosis. Occasionally, the endobronchial metastasis develop, and the endobronchial therapies, including debulking stent, deployment of laser cryotherapy, may be required for palliative symptoms. In some malignancies, there is a discrete stepwise spread to the liver and lungs, where in others, the primary lung cancer, pulmonary metastases are the marker of advanced systemic disease. It has been suggested that metastatectomy surgery can improve long-term survival. For example, the resection of the solitary colorectal pulmonary metastasis, it is associated with 5-year survival up to 50% compared to 5% of patients with untreated stage 4 colorectal carcinoma. The most common primary tumor considered for pulmonary metastatectomy is colorectal cancer. Other tumor sites commonly considered including the renal cell carcinoma, breast carcinoma, malignant melanoma, sarcoma, or germ cell tumor. Indications for surgery are the same for the primary tumor site, including fitness for surgery, which is determined by the extent of resection and evaluated with the lung function testing and assessment of comorbidities. The primary tumor sites are controlled. No extrapulmonary metastases are present and metastases are resectable. On the surgical option, no non-surgical options exist with better outcomes. In addition to the extent of lung cancer needs to be considered as performing pneumonectomy for the control of metastatic disease and can be hard to justify. Lung sparing techniques should be used to allow the subsequent resection if further metastasis may develop. As the majority of the pulmonary metastases are peripheral and symptomatic, they are usually detected on surveillance programs for the primary tumor found incidentally. Some patients present with symptoms which is suggestive of more widespread to the central disease. Symptoms include cough, chest pain, shortness of breath, and hemoptysis. Some tumor sites are more likely to develop metastatic endobronchial disease than others, such as renal cell carcinoma. CT scanning is a routine part of many cancer surveillance programs following the treatment of the primary tumor in the most common modes of detection, pulmonary metastasis. In addition to CT scanning, the biomarkers are used for surveillance for some tumors and may be raised in asymptomatic patients with pulmonary metastasis, including carcinoembryonic antigen, AFP, and human chorionic gonadotropin. Carcinoembryonic antigen, which is expressed in 93% of the patients with colorectal pulmonary metastasis, preoperatively erased serum carcinoembryonic antigen is associated with reduced 5-year survival following the pulmonary metastatectomy and colorectal cancer. A alpha-fetoprotein, which is associated with poor outcome in patients with hepatocellular carcinoma and non-seminaceous germ cell tumors. The human chorionic gonadotropin may be associated with poorer outcome in patients with non-seminaceous germ cell tumor. It is likely that the novel biomarkers will develop for the future clinical use and to help determine the prognosis, especially as the current selection criteria for surgery number of metastases is too simplistic and does not necessarily reflect the tumor behavior. Chest radiograph, which is poor screening tool for detecting the pulmonary metastasis, although the widespread metastasis may be easy to appreciate on chest X-ray, certain lesions are difficult to detect, including the apical lesions, retrocardiac lesions, small nodules throughout the lung fields. CT scan, which is the most important imaging modality, it can detect very small nodule 2 to 3 millimeter delineating anatomy provided information with the possible etiology of the nodule, detect extrapulmonary metastasis, ensure there is no local recurrence in the primary site. PET scanning is exclusive for the extrathoracic disease and stage the lymph node up to 10% of the patient with colorectal pulmonary metastasis will have the nodal involvement, and it should appreciate that the spatial resolution for PET CT is around 1 centimeter and the lesion is smaller than this may be detected. Magnetic resonance scan, where it is not usually required, although may be useful in determining whether the equivocal liver lesions may be malign or malignant. Attempts should be made to obtain the preoperative tissue diagnosis if possible, especially if the patient were there is a doubt of surrounding diagnosis for metastatic disease, and the differential diagnosis would change the management significantly. A solitary pulmonary nodule on the background of previously treated cancer should be considered with metastatic until proven otherwise. Exceptions include the patient with previous head and neck cancer, and breast carcinoma. There is alternative diagnosis is most likely. Often, if it is possible to achieve a definitive preoperative diagnosis, and surgery should be proceed to the balance of probabilities. Mediastinal lymph node involvement is the poor prognostic factor in metastatic colorectal cancer. The mediastinal lymph node metastasis have been identified in around 10% of patients undergoing pulmonary metastatectomy. A PET scanning as a part of the routine workup of the patient with pulmonary metastasis invasive staging on the mediastinum should only be performed if there is a suspicion of metastatic lymph node disease or PET or CT. The metastatic lymph node disease is detected, then given the poor outcomes, the palliative treatment is probably more appropriate than the surgery. A more aggressive approach has been advocated for these patients undergoing the preoperative and postoperative chemotherapy in addition to surgery. It has been argued that all the patients undergoing pulmonary metastatectomy should have a thoracotomy for palliation of entire lung to discover the undiagnosed nodules. In one study, one-third of the patients undergoing pulmonary metastatectomy has nodules undetected for conventional preoperative imaging, half of which are malignant. Despite these concerns, however, there does not appear to be any long-term survival benefit using thoracotomy. A VATS approach, however, is associated with reduced hospital length of stay and decreased morbidity. A more pragmatic management of algorithm involves use of VATS for nodules accessible for minimally invasive approach and thoracotomy for lesions not accessible for VATS. All disease should be removed with ensuring that the quality of the patient is not compromised. Quality of life is not compromised. All the functional lung as possible should be preserved to allow the potential future metastectomy options. Stapled wedge resection, diathermy resection, or segmentectomy are the preferred modes of resection, such as lobectomy. Although pneumonectomy is rarely performed for metastatic disease, it may be indicated for solitary but central metastasis that is not amenable to complete resection. Incomplete resection such as poor long-term survival. Despite large amount of data published, there is no randomized controlled trial to prove that surgical intervention influences long-term survival. While the non-randomized evidence may appear to favor the surgery, there is considerable bias as implied that all the patients should be from these disease without surgery. It could be argued that the patient with good prognostic factors, apparently good long-term survival and poor metastatectomy would have done well without intervention, as they represent a group with relatively indolent disease. The certainty regarding the long-term outcome of the pulmonary metastatectomy from the bias of pulmonary metastatectomy in colorectal cancer trials, which is multicenter randomized controlled trial of the surgery versus best non-surgical treatment in patients with colorectal pulmonary metastasis. It divides the patient into two groups: patients that could benefit to undergo metastectomy, including those with a single metastasis; patients that would indefinitely not undergo metastectomy, including those with multiple metastases; and the other poor prognostic factors, although these criteria vary from center to center. Patients that fall into zone of uncertainty, including those just one or two of the favorable prognostic factors. It is these that they are included in the trial, with each recruiting center allow a definitive zone of certainty. Indication of surgery in colorectal cancer are based on the same principles as the patient with pulmonary metastasis from other patient sites. They include the fitness for surgery, No external disease, pulmonary lesion to be resected is biopsy proven and highly likely to metastasis and less than 5 pulmonary metastasis, although it can vary. Patients with multiple poor prognostic factors probably should not be offered surgery or should be subjected to a more aggressive multimodality approach. The overall 5-year survival following the resection of colorectal pulmonary metastasis has been reported and published is 30 to 50%. A single metastasis with no poor prognostic factors associated with 5-year survival approximately 50%. Poor prognosis following the resection of colorectal pulmonary metastasis include number of metastases, original Duke staging, CEA levels, positive mediastinal lymph node, and short disease survival in complete resection. A patient with single metastasis in the presence of the normal CEA, an early stage original cancer, a disease-free interval is greater than the year, and no mediastinal disease would appear to be best candidate for surgery. Conversely, a patient with multiple poor prognostic factors should probably be offered metastatic surgery. 5-year survival following the metastectomy for the osteogenic sarcoma is better than that of soft tissue sarcoma. Factors associated with poor prognosis include increased number of metastases, short disease-free survival, short tumor doubling time in complete resection. As no randomized control evidence exists for the patient undergoing pulmonary metastatic with sarcoma, current practice is based on the case series report only. In 5-year survival following metastectomy for the renal cell carcinoma, in published cases series, no randomized control evidence exists to confirm the benefit of surgery. Factors associated with pulmonary prognosis include poor prognosis include no more than one metastasis, short disease-free interval, incomplete resection, and mediastinal lymph node involvement. Nephrectomy is associated with prolonged survival in patients treated with palliative chemotherapy for stage 4 disease. In some patients, resection of the primary tumor also resulted in incomplete remissions of the pulmonary metastasis without the need of thoracic surgery. The lung is the most common site of metastasis in malignant melanoma, affecting 30% of the patients that can occur with the treatment of primary pulmonary tumor. The median survival after the detection of the pulmonary metastasis is 7 months. The 5-year survival following metastectomy for the malignant melanoma is 18 to 33. In these cases, no randomized controlled evidence exists. In the view of poor long-term results, the caution should be taken, therefore recommending pulmonary metastectomy in this group of the patient. The factors associated with poor prognosis include more than one metastasis, disease-free disease is less than 3 years, incomplete resection. Chemotherapy is the treatment of choice for the patient with metastatic tumor. In patients with residual disease following chemotherapy, resection of pulmonary metastasis can be indicated if the serum tumor markers have normalized. Indications for surgery are lack of response to chemotherapy, recurrence during and after chemotherapy to determine whether the residual viable tumor is present, to resect enlarging benign hematomas, the teratomas element of the tumor. The 5-year following the metastectomy for the germ cell tumor is best for any tumor up to 75%. Factors associated with worse prognosis include raised preoperative serum tumor markers, alpha-fetoprotein and HCG, variable tumors of the resected specimen, and incomplete resection. Thank you.